Good morning, everybody. Welcome. My name is Howie Schneider, and I am the Dean of the School of Journalism here at Stony Brook, and I am also the co-director of our new Center for Communicating Science. I want to welcome you on behalf of not only the School of Journalism, but the Department of Public Health and the Political Science Department. All three of us are sponsoring this event today, and with very good reason. Because we're really here to talk about an issue that is currently at the intersection of politics and healthcare policy, and even communication and journalism. On March 22nd, in the East Room of the White House, President Obama signed the 2,700-page Patient Protection Affordable Health Care Act for America. It promises to be the most sweeping change to our healthcare system in more than 40 years. The President has said that this new act will provide access to care to millions of Americans who currently have no insurance, that it will bring down our healthcare premiums and costs, all of us, and actually reduce the federal deficit, and that it will provide protection for all patients that will ensure better and more preventive medical care in the future. 210 days after he signed this, and about 3 weeks after the initial provisions are going into effect, I think there's only one thing that we all here can say with certainty, and that is that the contentiousness, the controversy, the confusion about this Healthcare Act has not gone away. I just want to read you some numbers from two polls taken this month, well, October really, by the Washington Post and the Kaiser Health Tracking Poll about what Americans think about this new policy change. Washington Post interviewing likely voters in tomorrow's election, 36% favor revising the law so that it does more to change the current healthcare system. 37% want to repeal the law completely. Almost a 50-50 split. Overall, 52% of Americans hold an unfavorable view of the changes, and 42% support it, but strong opponents outnumber strong supporters 2-1. The Kaiser Health Tracking Poll this month and they track people over time, finds almost the same results. The country is divided right down the middle. 44% hold unfavorable views, 42% hold favorable views. While Americans tend to support individual pieces of the legislation that might help them, for the past year, the proportion of Americans who believe their own families will benefit in any way has hovered at only about 1 in 3. Underlying this is an extremely partisan debate. Democrats overwhelmingly favor the new change by a margin of 7-10. Republicans overwhelmingly oppose the new change by a margin of 8-10. And independents are divided. It will be, or it will take, years to determine the Act's long-term impact on American health. I think we will leave here, hopefully today, hearing from a lot of smart people who will give us lots of new ideas and points of view about what this new Act will actually do and how various stakeholders and sectors are getting ready to implement it and what we can expect to see in terms of change. But I think we all can agree that it's going to take years and years before we can assess the impact of this bill on access, cost, and quality of medical care. We have some very exciting speakers. We're going to start this program with 2 distinguished speakers. We're going to take a short break so we all get some more caffeine, okay? And then we're going to come back and we're going to have a panel discussion about how this act is going to be implemented, day in and day out, what changes we're likely to see and what impact it's going to have. So let me start by just introducing our first guest. And it is my pleasure to introduce this guest. He is the new Dean of the School of Medicine here at Stony Brook and the Vice President for Health Sciences. He is one of America's leading physician scientists, academic leaders. He's a person of great energy. I know that firsthand because I met with him recently at 6:45 a.m. in his office. He is a leading hematologist. He is a clinician, an accomplished clinician, but he has been a champion, and I know there are many students here, he's been a champion of the need to train more physician scientists who can bridge the gap between the laboratory and the clinical arena, translating research discoveries into improved treatments and technologies for the prevention, diagnosis, and management of disease. So will you join with me in welcoming Dr. Kenneth Koshansky?
Thanks, Harry, for that terrific introduction. Healthcare reform is one of the most important issues facing our nation today. Health is considered by many a civil right, and it consumes nearly 17% of our entire economic output in the United States. So it's particularly timely since we are concluding an election season when public policy in general and health policy specifically has been hotly debated that we entertain what healthcare reform is really about. Today, the Stony Brook University School of Medicine, the graduate program in public health, the Department of Preventive Medicine, the School of Journalism, and the Public Policy Program have assembled an expert panel. Led by international health policy expert, Dr. Karen Davis, the panel will inform and provoke us to think deeply about healthcare reform and the new healthcare reform legislation, the Patient Protection and Affordable Care Act signed by President Obama in March. This is a highly appropriate activity for an academic institution with a health sciences center like ours. We need to debate the issues of our day that impact our ability to meet our educational, our health service, and our research missions. We need to play a role in the policy process. Many of you heard me say that one of our biggest roles is to help mentor public policymakers and the public. We must connect with the vital issues of our day and involve ourselves in their outcomes. We need to involve our community in this process, both internal and external communities in these endeavors. We are greatly affected by the national health care policy in relation to all of our roles at an academic medical center, the clinical care, the research, and the educational missions. In academic settings, we ask questions, we explore issues, we look for solutions. With our panel of experts today, presenting various sides of the healthcare education and reform debate, we hope to answer a central question of current healthcare reform and its implications. Why don't people get it? Fleshing out the law and its potential impact is critical for all of our understandings. For those of us in the environment of an academic medical center, we need to understand how the law will impact us. And we have questions such as, how will the law impact our delivery of care nationally and at Stony Brook University? What about health care for vulnerable patient populations? Will it truly impact their ability to seek high quality and receive high quality health care? Will provisions of the law better support preventative medicine and primary care? Clearly two of the tenets of the law. Will the law in some way help advance necessary research, understanding the magnitude of the problem? Will it support translational medicine, taking our understanding of healthcare and turning it into better healthcare for our citizens? We hope you'll learn today from today's discussion on healthcare reform, bring your knowledge to the debate, Share with our colleagues and with our students today. And please participate by asking questions at the end of the forum. Thank you.
Thank you, Dr. Krashansky. Dr. Krashansky will be here to hear Dr. Davis, who is our keynoter, and we'll have the opportunity, I think we're hoping to get him back up to talk a little bit about what Stony Brook in particular is doing to get ready for all these changes and what it's likely to mean here at the medical school and the hospital. I want to now introduce one of my colleagues who will introduce our keynote speaker. Peter Salins is the former provost and vice chancellor for academic affairs of the State University. He was the provost of SUNY. He is the director of our public policy graduate program in our Department of Political Science. He is the author of many, many books. He has served on Mayor Giuliani's advisory commission on the Health and Hospitals Corporation. And so he's had a lot of experience both working in policy and now teaching policy. So will you join with me in welcoming Peter Salins?
Good morning. It is indeed an honor to introduce our keynote speaker this morning, Karen Davis, President of the Commonwealth Fund. The Commonwealth Fund is perhaps one of the United States' most prestigious national foundations dedicated to the advancement of American standards of and access to quality health care. And Karen is in her own right one of the most respected national experts and advocates on healthcare issues. Karen has a most extensive and distinguished background. A nationally recognized health economist, she has served in key public positions in academia, government, and the nonprofit sector. After earning her doctorate in economics from Rice University, she served in the faculties of Rice and Harvard, was a senior fellow at the Brookings Institution, a cabinet official and administrator in the U.S. Department of Health and Human Services, chairperson of Johns Hopkins Department of Health Policy and Management, and since 1994, president of the Commonwealth Fund. Karen is also a prolific author in the field of health and social policy. In addition to 6 books and numerous monographs, she has authored an exhaustive and exhausting to contemplate series of articles in the most prestigious scholarly journals in the fields of medicine, health, and social services. Most important, however, beyond Karen Davis's stellar professional and academic bona fides, is her passion as a healthcare advocate. At Commonwealth, from her former academic pulpits, on countless commissions and study groups, in talks like the one she will deliver today, Karen has been a loud and clear voice calling for an American healthcare system that should not be only qualitatively the best in the world, but whose benefits should be available to all Americans, regardless of their income class, geographical home, or social background. Her most recent contribution in this regard has been as a member and supporter of Commonwealth's Commission on a High-Performance Health System. The Commission's reports and policy recommendations played an important role in shaping the national health reform legislation adopted by Congress earlier this year, officially titled, this is the 3rd time you've heard the official title, the Patient Protection and Affordable Care Act, that is the central subject of our symposium today. It is now my great pleasure to give you Karen Davis.
Thank you, Peter, for that lovely introduction. What he didn't say is that Stony Brook has a special place in my heart as the first organization to offer me a job when I finished my PhD in economics at Rice. And while I wasn't able to come to Stony Brook at that time, I'm delighted to be here today. I must also say how impressed I am at the different units here at Stony Brook that are sponsoring this seminar today. I spent, as Peter indicated, a decade at Johns Hopkins in the School of Public Health, and dividing the public health school and the medical school was something called Wolf Street. And they said, you never cross Wolf Street. So to see the School of Medicine the School of Public Health, the Department of Preventive Medicine, joined by the School of Journalism and the Public Policy School, all together sponsoring this, to me is quite an accomplishment. And I think it's appropriate given the subject of this symposium, which is, why don't people get it? So to have the journalism school kicking this off and helping us understand the gulf between what is in these 2,700 pages and what the public understands about it, I think is particularly important. I was also struck by Dr. Koshansky's indication that he would share with us some of the thinking of the health sciences about how they position themselves with response to the Affordable Care Act. And that's what I find in the newspapers, in the media, what you think the debate has never ended. It still rages as if the legislation wasn't enacted. And certainly for the public and for politicians, it's very much still an active issue. But in group after group that I go to, everyone is figuring out how it has accepted that it is the law of the land and figuring out how to position themselves to really take advantage of many of the wonderful opportunities that are contained in those 2,700 pages. It's particularly fitting, I think, that Peter and the Public Policy Program are involved, because the other thing that I sense is people are hard at work at the federal and at the state level with all of the thorny issues of implementation. This will be complex. It's going to roll out at least over a 4-year period and really over a decade before all of the provisions of the Affordable Care Act are implemented. And certainly those in the administration who are charged with implementation very much focused on the regulations and the whole rulemaking process and the issues that need to get resolved as the specifics of the way this legislation will work get rolled out. Obviously, they are watching the elections, as we all are. What perfect timing to have this symposium the day before the election. And looking at what the implications of the election will mean for implementation. Obviously, you hear a lot in the media about repeal. I don't think anyone thinks that President Obama would sign repeal legislation or that Congress would override that veto. But there is a lot of focus on appropriations, the money that it takes to really implement some of the provisions, which ones are automatic, funded through entitlement or pre-funded trust funds, which ones require appropriations, and which specific provisions might be vulnerable to modification. So that's more the nature. But just a final thanks to Jean Alessandro, whom you'll see on the panel a little bit later, graduate student in the School of Public Health. And that's really why I'm here today. I never turned down a student. So if there's a request from a student to speak, I try, if at all possible, to honor that. So I hate to hold her responsible for what I'm going to say, but she's responsible for my being here. I think it's easy as we talk about many of the controversial provisions in this legislation to forget the path that we were on prior to implementation of the Affordable Care Act. And I won't spend a lot of time on the problems, but it simply was unacceptable to continue on our current course. Recently, the Bureau of the Census announced that we have 50 million Americans who are uninsured. That is an all-time high, not only in the absolute numbers, but the proportion of the population that are uninsured. And in some ways, that's just the tip of the iceberg. Our own studies at the Commonwealth Fund indicate that another 25 million adults are underinsured, and even though they have insurance, it's not adequate to protect them against the financial burden of medical bills, and many of them have accumulated medical debts. So the one inescapable fact is that if we had continued on our course, we would have had ever-growing numbers of uninsured. Some estimate 60 million by the end of this decade. The Congressional Budget Office estimates with reform that will drop significantly over the decade. As I mentioned, 25 million are underinsured, but many have serious problems with medical bills. Again, our study suggesting that as many as 72 million report difficulties either paying bills or having accumulated medical debt. Healthcare cost is certainly a lot of discussion right now about the fact that health insurance premiums are going up. Health insurance premiums have been going up. So the average family premium in an employer plan was 11% of the median family income back in 2000. It is 18% today. Without this reform, it would have gone to 24%. We simply could not accept having a fourth of Americans' income effectively going for health care. But for the American people, the real problem with our healthcare system is that it's a very fragmented, siloed system. You get services in different places, in different settings from different providers. There's very little coordination of that care, and patient time is wasted, often as they experience repeat services, whether it's repeat tests or having to go back to a specialist because their information was not provided by their primary care physician, or their various breakdowns in getting information and test results to their providers. In fact, about half of Americans in the surveys that we've done report various failures of coordination of care. So overall, we spend twice what other countries spend per capita on healthcare, but we do not get commensurate value for that spending. The Commonwealth Fund has supported for over 12 years international surveys of countries and both patient and physician experiences with care. Those come out in annual surveys published in the Health Affairs Journal, but we also synthesize them in a report called A Mirror Mirror, looking at 67 different indicators across major domains of care. And typically, the U.S. is last or near the last on all of those domains of care, and overall ranks last among the countries included in our surveys. So I think there's little question that we needed to change course. There may be a division. There was a division even at the time. I would say all of the surveys kind of showed a one-third, one-third, one-third split before reform. Those who wanted more, something that would be single payer, comprehensive, cover everything free of charge. Those that wanted more of a market solution, vouchers for people to buy insurance on their own. And then those in the middle who favored building on what now exists and addressing the most serious problems in our system. So I think only recently we've learned that some of those polls, about 44% being unfavorable, include those who wanted a lot more, as well as those who didn't want anything at all. So what exactly is in this act? Again, a lot was made of the number of pages, its height, its weight, but very little about the provisions that it actually contains. I think the most important things are the coverage of the uninsured, with an estimated 32 million people being uninsured. But it also makes health insurance affordable to people up to 4 times the poverty level. That's a family income of about $88,000 for a family of 4. They all get assistance paying their health insurance premiums. Those up to 2.5 times poverty get assistance with their cost sharing. Basically, people are guaranteed that they won't have to pay a premium that in excess of 9.5% of their income. So it's extensive assistance to really make health insurance affordable, not only to low-income people, not only to uninsured people, but to middle-class families. There's a lot of concern about seniors who have been led to believe that their benefits are being cut. In fact, there are improvements in benefits in the legislation, including the elimination of what's called the donut hole in the Medicare Prescription Drug Act. Again, phased in, doesn't totally happen until 2019, but an important improvement in that one glaring deficiency in the Medicare prescription drug legislation, as well as other provisions, including coverage of preventive services without cost sharing, And probably one of the biggest sleepers that nobody mentions is the beginning of new long-term care insurance program. It's voluntary. People contribute starting in 2012 through payroll deductions, but they will, after 5 years, be vested to receive monthly checks to provide long-term care services, including those needed to help them maintain their independence at home. For me, the most, and there's no way that I can spend this morning talking about all the provisions, so the most exciting ones to me are those that would change the delivery system, that would try to emphasize prevention and primary care, that would lead to a more organized delivery system, and the changes that are being put in place to really change that path of rising costs and to try to get greater value for what we're spending on healthcare. So it's important to realize the potential that is represented by reform, but that will require groups like those in this audience really understanding the legislation and coming together to make the most of the opportunity that is there. Just to be a little more specific, maybe the most controversial provision is called the individual mandate. It does require people to have health insurance. If they don't, they initially have to pay $95 in 2014. It goes up to $325. It goes up to $695. So eventually, by 2017, people will have to pay about 2.5% of their income if they do not have health insurance coverage. So there is a requirement that people have health insurance coverage. And that probably has been the most controversial. It's the subject of a lot of Attorney General lawsuits against the legislation. But it's integral to the legislation because insurance only works if healthy as well as sick people are covered. And if healthy people, some of the people in this audience, healthy young people, have the ability to opt out of that legislation, then the premiums will be very high. Because what is included in the legislation is a requirement that premiums not vary by health status. Everyone must be eligible for coverage without paying a higher premium because of a pre-existing health condition or a health risk. The one difference was it can vary by age and it can vary by smoking status, but it cannot vary by your health status. And that only works if everybody is covered. Employers are required to share in the responsibility. Again, you'll hear different views on this, but it simply isn't feasible for the federal government to pick up all of the tab. The main way Americans get health insurance is through their employer. 160 million Americans get coverage that way. If employers were to drop that coverage and leave it to the federal government to solve, it would require substantially more commitment of resources that are contained in this legislation. So partly to keep employers from dropping, but also to create a level playing field, firms with 50 or more employees are either required to help finance coverage for their employees or pay a contribution that works out to about $2,000 per employee. That's larger businesses, small businesses are eligible for tax credits. There are various market rules that include not only community rating and open enrollment, which guarantee coverage on the same term to everybody regardless of health status, but also provisions for reviewing premiums, and one of those that's made the news a lot, requiring that a certain minimum of the premium actually go for health care. 85% in the case of large employers, 80% in small. States will set up by 2014 health insurance exchanges where qualified health plans will be offered. They must meet an essential benefit standard of comprehensive benefits, and as I said, there are sliding scale subsidies for premiums and for cost sharing. There are also a number of payment reforms and system reforms. We do stick with our mixed public-private system of financing. The Congressional Budget Office estimates that the proportion of people covered under employer-sponsored insurance will continue, much as it is today. But the 32 million people who will be covered, about half, 16 million, will be covered by the Medicaid program. which will cover everyone regardless of family situation up to 133% of the poverty level, and 16 million will be covered through these new state health insurance exchange. Health insurance premiums will continue to rise. Our own studies indicate that they will rise somewhat less than they would have pre-reform, representing about a $2,000 saving in 2019 for the average family, or another way of thinking about it is about a $2,000 tax cut. We also estimate that the growth in health expenditures will slow. It will still go up as a percent of the gross domestic product, but it will go up at about a half to 0.6 percentage points a year less than it was projected to increase pre-reform. That may seem small, but 1% or 1.5 percentage points really make the difference in bringing our costs more in line with those of other countries. The Act is controversial, I think, in large part. If you had to ask me why why there is so much controversy, it is because it's paid for. Despite a concern on the part of the American people that it's going to add to the deficit, the legislation went to considerable pains to identify pay-fors, to identify ways of financing about $938 billion in additional cost for coverage of individuals. About half of that financing comes from changes in the federal budget, largely for the Medicare program, and there are two that I would stress there. There's about 180 billion, I'm having trouble with my own eyes, 160 billion that comes from what are called productivity improvements or provider payment changes. Basically, the American Hospital Association said that they would get additional money as the uninsured were covered, and they were willing to take slower increases over time from the Medicare program. So it's important to understand that. It's an increase, but it's a 1 percentage point less of a raise, if you want to call it that, than was projected pre-reform, agreed to by the American Hospital Association because they recognized they would have less bad debt as the uninsured were covered. So when you hear about seniors having $450 billion worth of Medicare cuts, what we're talking about is $160 billion of slower payment increases to hospitals because they agreed to that in exchange for having coverage of the uninsured. It's not a cut in benefits. And it's not even an absolute cut in payment rates. It is a raise that is less as a result of this legislation. The other major provision that generated about $204 billion worth of saving is an end to the overpayment to private managed care plans under Medicare to pay them eventually at the same rate as it would cost the Medicare program if people were covered through the Medicare traditional program. Well, I shouldn't just jump over the other revenues in case people are interested in that bottom line. This is another nice word for increased taxes, but there are increased taxes on families with incomes over $250,000. So effectively a 3.6 percentage point increase in the income tax for higher income individuals, as well as a tax on unearned income, dividends, rent, capital gains, to make it comparable to what is taxed under the payroll tax for those underage with incomes under $250,000. There are also additional fees on pharmaceutical industry, medical device industry, insurance industry that all add up to those. So each of those was hard fought, very controversial, difficult votes for members of Congress to take. But the basic bottom line is the congressional budget estimates that the expansion of coverage is paid for, and there is a net reduction in the federal deficit of $143 billion over 10 years. In addition, the Congressional Budget Office estimates that there will be a further significant reduction in the federal deficit as a result of this act in the second decade of about 0.5% of gross domestic product. Again, estimates are that that's talking about $1.2 trillion of deficit reduction in the second decade of this legislation. So that's important to know because with the budget rules in Congress, any repeal would have to come up with $150 billion worth of ways of saving the money that's in the first decade. And obviously, Congress would then need to also grapple with the long-run federal budget deficit that would occur without these changes. So why am I particularly enthusiastic about this legislation? It is first and foremost the coverage. It is changing the situation in this country where people who need health care are simply unable to get it because they cannot afford it. It covers significant numbers of the uninsured. My own guess is it will cover more than the Congressional Budget Office estimates. The only ones that are explicitly excluded are undocumented workers that about 8 million people are not covered who are not legal residents in the U.S. But for others, it provides coverage, improves affordability of both medical care and health insurance. It also fundamentally changes the way the insurance industry operates. Right now, the insurance industry makes money by avoiding people who are sick, and they put a lot of energy into excluding people who are at high risk. A lot of money goes for underwriting, for commissions. The creation of the insurance exchanges will markedly reduce what I think of as waste in the healthcare system with high administrative costs. The provider payment and delivery system reforms, I think, are very important. They start in a small way with pilots. In 2011, the Centers for Medicare and Medicaid Services will be establishing an innovation center to test things like patient-centered medical homes, bundled payment for hospital and post-acute care services, and in 2012, the Centers for Medicare and Medicaid Services are charged with implementing what is sometimes called a shared savings program, sometimes an accountable care organization program, but basically creating a new provider category in Medicare that will be paid in a fundamentally different way. So it's right now physicians participate, hospitals participate. You will have a new provider category called accountable care organizations. There's our conferences going on every day, webinars going on every day, people trying to figure out what is an ACO, how can they be one. But there are about 17 requirements in the legislation that specify that it will be a provider organization. It's not intended to be an insurance product, but rather a provider organization that is accountable for the total care of patients, from everything from preventive care, primary care, specialty care, emergency care, acute care, post-acute care, everything that's covered under Part A and Part B of Medicare. They are accountable for the total care of patients, and they are accountable for the resources that are used in the care of those patients and in the outcomes that are achieved for those patients. There's also, again, a provision in the legislation called the Independent Payment Advisory Board. There have been members of Congress who've already introduced legislation to repeal this provision. The American Hospital Association made it clear that they were never for this, and they are still against it. And basically, what it is a new body of 15 experts, independent, full-time people, appointed by the President, approved by the Senate, that would begin, starting in 2014, to make recommendations to slow the growth in Medicare outlays. If spending is projected to exceed a specific target, they must make recommendations that would bring spending within line with that target. Congress must consider those recommendations in an accelerated process. If Congress fails to act, those provisions become law. And they basically give broad authority to the Independent Payment Advisory Board to make any recommended changes in payment that they deem would be appropriate. So those could be what I think of as the old-fashioned rate cuts, so limiting the rate of increase or what's called the market basket update for providers, or it could say certain procedures are overpriced, they should be reduced, or they could say there's abuse in this geographic area, that ought to be addressed. They could say bundled payment for acute and post-acute care makes sense. We ought to move to that system of payment rather than itemization, fee-for-service, broad authority to make payment recommendations. They cannot touch benefits, eligibility, cost sharing, premiums, but they have broad authority to affect payment. Now, the other fine print is that all of the providers that gave in the first decade, the hospitals and others, said that they don't have to be hit again until after 2019. So again, the full effect of this will take time, but some of that second decade savings come from the authority. And what it really is moving, Peter, these payment decisions out of the political process in Congress. Because I think what we saw with health reform, very difficult for members of Congress to vote for something that maybe home health agencies are overpaid, but correcting that becomes very, very difficult in the political process to do. So they're leaving it to an independent payment advisory board. In addition, the board would make recommendations on private sector payment. These are non-binding, but they are required to make a report every year about the total health system and the kinds of changes that would be appropriate in the private sector as well as in Medicare, and also recommendations in Medicaid. So that's some of what's in the legislation. Let me focus just a little bit on the Accountable Care Organization and the models of payment and care delivery. Again, in these politically divisive times, it became controversial even to appoint an administrator of the Centers for Medicare and Medicaid Services, but Dr. Donald Berwick is now the administrator. And he spoke at a conference that we sponsored on patient-centered medical homes. And when asked what advice he would have for the group that was gathered there, he said, stay together and stay the course. Don't wind up fighting between the primary care and the specialists. Don't fight between the hospitals and the group practices. Don't fight based upon whether you're a teaching hospital or not a teaching hospital, or nurse practitioner versus a physician. Stay together. That's the only way this legislation will work, and it's going to take a long time to work all of this out, so be prepared to stay the course. But he said, if you are bound together by an authentic desire to achieve the triple aims of better population health, better care, and lower cost, this will resonate with the public and with everyone. You can be bound together in a shared desire to achieve the best care for your patients in pursuit of these changes. So what our Commission on a High-Performance Health System, which initially came up with this notion that there's a continuum of care delivery, and it's very much linked to the way in which you pay. Dr. Tony Shih developed this at the Commonwealth Fund for our commission, this graphic, that the more organized the delivery system, the more able it is to move away from the fee-for-service method of payment, to really take a global payment and be accountable for the total care of patients. But we see at least three different models. One, a patient-centered medical home network with an infrastructure provided that would help them be able to coordinate care, to implement care redesign with the help of an infrastructure, in some cases provided by state government, which is what Vermont and North Carolina are doing, sometimes provided by an insurance company, which is what the Blue Cross Blue Shield of Michigan is doing. But basically a network of independent primary care practices that are able to take accountability for a defined set of patients. Now, what works for them is more of a blended system of payment or a global primary care fee. Going at risk for services beyond primary care is very difficult in that kind of an organization. The second kind of ACO is a multi-specialty group practice that has the whole panoply of physician specialties there. For organizations like that, they can take more bundled payment, including perhaps global fees for, say, surgical conditions, all of the preoperative, operative, postoperative care that's involved. So another model of ACOs. And then finally, integrated inpatient and ambulatory care organizations that can be accountable across the entire spectrum of care and perhaps take a global payment for that with risk mitigation. I don't think anybody is very comfortable with full capitation, but having Medicare program partner with accountable care organizations to provide reinsurance or stop loss, perhaps some administrative functions like paying out-of-network claims could make that type of payment feasible. And in all of these models, finding a way of providing value-based purchasing with appropriate rewards for quality and permitting the ACOs to share in savings. If you want more information on that, I'll plug the CommonwealthFund.org website, where we've been putting out a series of reports to help people understand the provisions of the law. But let me just share some of them with you. One particular data brief looks at women and how women are affected. Senator Mikulski said that being a woman is no longer a pre-existing condition. So I think that kind of sums up what is there. When I said you can't charge people more by reason of health status, you cannot charge them more by reason of gender. Only age or smoking status or family status affects the premium, not male or female. And obviously there are important provisions with regard to benefits that are covered, as well as since women tend to be lower income than men, obviously all of the provisions to make health insurance more affordable are a particular benefit to women. There are also provisions that are a benefit to small businesses. I said that employment-based coverage is the primary way people get covered. In fact, for firms of 200 or more employees, for all the talk about the erosion of employer coverage, 98% of those firms offer coverage to their employees. The experience in Massachusetts with the individual mandate is that even though employers had only modest financial contributions if they didn't provide coverage, employer coverage went up by 11%. Because when people needed coverage, they took up, because of the individual mandate, they took up coverage that was offered, and more employers offered coverage to make sure that their employees were able to meet the requirements of the legislation. The real problem is with smaller businesses that has never been able to get the same kind of premiums that large businesses get. They pay higher premiums for fewer benefits than larger employers. The creation of the health insurance exchanges would give them more of a level playing field with large businesses, make it administratively simpler for them to cover their employees and to offer their employees choices through the exchanges. But there are specifically tax credits that pick up 35% of the cost of small business premiums under the legislation. There are also important provisions for young adults. The good news for this room is that people can stay on their parents' health insurance policy until they're age 26. So that went into effect on the 6-month anniversary of the Affordable Care Act about 5 weeks ago, helping about 1 million young adults obtain coverage. What's less talked about is that nearly all young adults have incomes that will qualify them for assistance in 2014 once the insurance exchanges and the expansion of Medicaid go into effect. Approximately 7.2 million low-income young adults with incomes below 133% of the poverty level would be eligible for coverage under Medicaid, and another almost 5 million would be eligible for subsidies, which go up to 4 times the poverty level. Another major implication of the legislation is its implication for better care, better health outcomes, significant investment in primary care and prevention. The fine print is that the prevention trust has $15 billion that has already been appropriated, already set aside. So that is not subject to, say, a freeze on new appropriations for implementation of health reform. So committed funds. In addition, there's a 10% increase in Medicare payments for primary care services in the legislation, and a provision that will bring Medicaid payment for primary care up to Medicare levels at least 2 years, 2013, 2014. What happens after that, the legislation doesn't specify. There's a major expansion of community health centers, about $11 billion in increased funding for community health centers over 5 years that would almost double the capacity of community health centers to serve vulnerable populations. There are major provisions to increase the information on performance, on quality, and cost in the legislation, and certainly major incentives to improve health outcomes quality. There are also some sticks that would reduce payment for hospital-acquired infections or for high rates of avoidable hospital readmissions. The legislation really emphasizes what was already in the economic stimulus legislation, American Recovery and Reinvestment Act, to promote the adoption of health information technology and to invest in comparative effectiveness research. So that's what's in the legislation. That's its likely effect. Is it a perfect legislation? No. Are there concerns about things that could unravel? Yes. My mind is whether employers will continue to provide coverage, whether insurance premiums really will abate as markets become more competitive, whether hospitals, health systems will respond to the opportunities for innovation. Will the affordability provisions be adequate? I talked about the $938 billion that spends on coverage and premiums and cost sharing, but it's still a chintzy bill. Truthfully, you get right down to it in the campaign. Most people thought it would take $1.5 trillion to do the job. It has tried to do it on the cheap. Will more subsidies be required, or will more people be exempt from the individual mandate because of the hardship exemptions that are in the legislation? I worry a lot about what will happen to the safety net between now and 2014 as we have continuing economic problems, continuing fiscal problems at the state level before the big expansion in insurance coverage comes in 2014. And whether the incentives for primary care and care coordination are really strong enough to offset some of the very strong incentives that are in the legislation, and whether, in fact, federal and state governments can continue to move forward with effective implementation. Having said all of those caveats, there's no question that this is historic legislation. Teddy Roosevelt in 1912 proposed this legislation, where a century later many presidents tried and failed, from President Truman. I worked for President Jimmy Carter, just to date myself, and was responsible for developing his national health plan. And people in this room probably remember the Clinton attempt as well. So presidents have tried and failed. This is historic legislation, and it really should make major strides toward the achievement of goals. It will require oversight. It will require modifications as we learn going forward. It's important to learn as rapidly as we can as we roll out many of the innovations that are in the legislation. People in this room have a major role to play in ensuring the success of the legislation. That includes being active in your participation in many of the innovations that are envisioned in the legislation. Certainly there's a lot of research and evaluation that needs to take place, but I would just echo what Don Burke said. The important thing is to stay together and stay the course. Thank you very much, and thank you to my colleagues at Commonwealth Fund. I would say the whole word rationing was kind of the first major attack on the legislation, that it was going to lead to death panels. We were going to decide certain lives weren't worth saving, and the government would, in fact, terminate care, deny care for people with serious conditions or disability. And some of this related to what are called comparative effectiveness provisions in the legislation. The Economic Stimulus Act included $1.1 billion for research to find out what works, what doesn't work, and what works better or the same as something else. So if it's a drug for lowering cholesterol, are they all the same, or do some have particular advantages? What the legislation did was to create something called the Patient-Centered Outcomes Research Institute that would set priorities on the, it's an independent private entity, would set priorities on the research and effectively disseminate the information that comes out. So doctors would know about it, patients would know about it. What it did not do was tie that research to insurance benefit design or to pricing. So there's something called reference pricing, which says if one drug doesn't work any better than another, we won't pay more for the more expensive drug. We will pay at the price of the least costly way of treating that condition. There's also something called value-based insurance design that says if this is effective and really essential, then people shouldn't have cost sharing that deters them from getting that. On the other hand, if it is discretionary, if there is a question about whether an MRI is needed for a sports injury, maybe people should pay more for that. But the law did not take the step of tying comparative effectiveness research to either covered benefits or the price that's paid for covered. Our commission on a high-performance health system found $600 billion worth of savings over 10 years if you would be willing to tie that research. To me, as rational scientists, we should want to get our money's worth and pay for things that work, encourage use of things that work, discourage things that don't work or don't work any better than the alternatives. I don't know whether the dean wants to chime in on that note or.
Thanks, Karen. The rationalization, I agree completely, bad word to use politically on every level. The statistics are clear. We know that something like 90% of healthcare dollars are expended in the last year or so of life. And if we understood better on a research basis what works and what doesn't work, that is where most of our efforts could be directed. But there is no tie in, there is no incenting that kind of better use of research and outcomes to healthcare affordability. I think that if we were able to establish institutes in medical schools like Stony Brook, where we could support faculty members to study it at every level, in practice, at secondary healthcare centers, at tertiary healthcare centers, we would be much smarter about where we should make logical decisions. The pharmaceutical industry does bear a big part of this. If you had to invest in an industry that has protected its profit margins over the centuries, it would be the pharmaceutical industry. The costs just keep going up. One of the most irrational things in the drug approval process is the cost to develop a new drug, hundreds of millions of dollars, which is then passed along in the use. That's why new drugs are so expensive. If they are no better, if they're just as good as the available drugs, why should they be put into the marketplace? Why should your physician prescribe the more expensive drug? Because they have been visited by all sorts of people who have convinced them, not on evidence, but on, how can new not be better? There's a lot of irrational decisions being made that is not based on data, and the quicker we get to understanding healthcare decisions on a data basis, the better off we will be. I'm a strong proponent. If you can find an advantage to a new drug or a new device or a new medical technology, absolutely, bring it on. But a lot of what we do is not based on evidence that something is better or more effective in healthcare. So we just do need to study this more, and we need to study it in greater depth and make some logical decisions based on what we learn.
Dean, I'd be very curious whether the university is thinking about any of the innovations that are being envisioned for the Innovation Center or the Accountable Care Organization provisions.
So there are a number of things that Stony Brook University is implementing in the healthcare reform legislation that ought to be able to make an impact. One of the key provisions, one of the key assumptions in the healthcare reform is that if we can invest in primary care physicians who have a terrific understanding of these kind of issues, that we will be better off. We'll deliver better care, we'll deliver more compassionate care, and more effective and affordable care. About 2 months ago, I was actually at the White House. We were in several of the deans of the New York medical schools had a meeting with Zeke Emanuel, who is President Obama's chief healthcare advisor. And the subject of primary care and how do we entice young physicians to go into primary care professions, and by that I mean general internists, combined medicine pediatric physicians, and family medicine physicians. How do we encourage? The point we were making is it's difficult. Over the years, I have watched the number of people who go into primary care dwindle. And to a large measure, it's improperly aligned incentives. A general internist will probably make the lowest salary of any physician that comes out of our healthcare education system. And yet, these are the people who are going to be making the most important decisions in your healthcare. The primary care physician has to know all about all of medicine, has to know when you have chest pain, is it cardiac or is it acid reflux? If it was up to you and you had chest pain, well, I want to go to a cardiologist to figure it out, and the cardiologist is going to order all sorts of tests, stress tests and others. But if I go to my primary care physician first, they'll figure out perhaps that it's just a little bit of antacid is all that's necessary, and save tens of thousands of dollars in evaluations and the like. We need to figure out a way to invest in primary care training, give our primary care trainees the right tools to make the right decisions on. And at Stony Brook, we are now trying to incentivize our young people to go into those kind of career pathways. One way to do this is to create a series of role models of medical educators that are very supportive of this, is to give scholarships to people who want to go into primary care areas, to make our residencies in the primary care areas more attractive to young people, to create a panel of medical educators that focus on primary care education. So that's one way we can, at an academic medical center, improve upon that. The other way is to invest in quality, to use metrics and use the electronic health record to improve patient care. When I was back, before coming here, I was at the University of California, San Diego as chair of the Department of Medicine there. And we put in place a very simple question. How good are we at UCSD at preventing blood clots in our hospitalized patients? This is an area that is really vital to good health. We know that it is a silent killer, developing blood clots usually in your legs when you're, in the hospital because you had a hip fracture or you had an operation. How good were we at UCSD, an academic medical center with a good reputation? How good were we? We used our data gathering services, and we found that, and every 3 or 4 years, the guidelines on best practice is published in the journal Chest. How good were we at living up to those guidelines? 52% of the time. We were doing the right thing. And this is an academic medical center. We put in place a number of quality improvement methodologies. We did physician education, resident and attending physician education. We put in place an electronic order entry system that allowed the physicians to do the right thing. And then we looked back again, and it was 98% compliance with those guidelines. We calculated we saved over those 6 months that we implemented, we saved 6 lives and $800,000 in the process. And so we really do need to make a science out of healthcare quality, because it's the right thing to do and it's the affordable thing to do. And so I would argue we really need to institute those kind of information systems and educational systems and encourage people to remain in primary care. So those are some of the things we're doing at Stony Brook.
Well, thank you. I'll go back and take questions from the audience, but I loved getting that story about the blood clots out of the dude, because our commission on a high-performance health system really tries to identify best practices and innovative models, and then, like Johnny Appleseed, kind of talk about them and spread them all over the country. And to me, that's what's exciting about this legislation. It's really a formalized way of trying those kinds of innovations and then systematically trying to spread best practices, in part by having performance, so you know what your rate of blood clots is and how it compares with peer institutions. And a lot of our scorecards on health system performance focus on the 90th percentile. Can we bring everybody up to the 90th percentile and save lives and save money? So other questions?
There's one back here.
The difference between ACOs and HMOs, and would they be better to implement some of these incentives to save costs and still provide good care?
Will this just be a repeat of the managed care movement of the 1990s? And again, talk about things one worries about. I feel like the HMO Act, as Senator Kennedy envisioned it in the 1970s, it was to take the Kaiser Permanente prepaid group practice model of care and spread that by giving grants and loans to establish those organizations. In the 1990s, it became captured by the insurance industry. And looser forms of managed care that were not really delivery systems, but discounted fee networks of providers that mostly used fairly arbitrary utilization review mechanisms to deny care. So save money by paying less and restricting access. And obviously there was a patient backlash to that, and the savings didn't necessarily go to lower premiums, but because of the consolidation of the insurance industry, really went to higher profits for insurance companies. So how will ACOs not repeat that? And it's something our commission is grappling with. Obviously, the main thing to me is to stick with this. It is to be a provider organization. I would also like to see it as a nonprofit entity. The one conflict of interest I have, I serve on the board of the Geisinger Health System, which is a nonprofit entity that has its own nonprofit insurance plan, and that really tries to have the insurance plan partner with the health system to improve care. And very much, as the dean said, identifying 40 best practices that are involved in having perfect coronary bypass surgery with low complication rates, and then being rewarded for that because they take a global fee with a warranty where everything's covered, including if there's any need for rehospitalization or re-surgery. So stay tuned. I think that's exactly the concern of whether there will be safeguards as this rolls out. I think a lot of it is transparency. A lot of it is an emphasis on evidence-based medicine as opposed to what was called the being Milliman and Robertson's arbitrary, one-day mastectomy, one-day delivery types of guidelines, to really have evidence-based guidelines, a lot of transparency, but it's going to take a lot of understanding on the part of particularly Medicare beneficiaries whose physicians are participating in accountable care organizations, that they really understand and understand how they can benefit from that form of care. Yes, down here?
What entities do you feel have had a major role in?
Those that have to change or lose money, we're not as enthusiastic about it. I'm not the political side. I should deflect this to you, Peter. But the key issue was the insurance industry, and where did they come out on this? And the insurance industry has many different kinds of players. You obviously have the plans like Kaiser Permanente that will benefit from this legislation because they will be offered in the insurance exchanges. Right now, employers will pick a commercial carrier that can offer a lot of different options for their employees. And so they don't offer Kaiser Permanente. But in the insurance exchanges, you can reach the small business and individual market. So for those companies, they will gain. But for many of them, this community rating, the medical loss ratio, the review of premiums is very threatening. Insurance brokers, commissions are likely to go down. On the face of it, the insurance industry did not mount ads, Harry and Louise ads attacking health reform. But there were allegations of money being channeled to the Chamber of Commerce that did. I think the insurance industry was primarily worried about. The pharmaceutical industry made their own deal, which basically said, if you don't negotiate drug prices or allow re-importation, then we will contribute the money to eliminate the donut hole in the prescription drug benefits. So fairly progressive. The industry canned the head of their professional organization, lobbying organization, afterwards, thinking they gave too much. But I think on the whole, people thought they did. The medical device industry pays a modest fee. They vigorously fought tying comparative effectiveness research to insurance benefit design or reference pricing. The business community, and Fred will give you a chance to hear their perspective later, just had a hard time swallowing government intervention in the market. A concern that they were going to have to pay more if you covered everybody who was sick, that somehow it was going to drive up their premiums. If you tried to get a good price for the coverage of the uninsured by covering them, say, under the Medicaid program or through the insurance exchange, there was a big proposal for a public option that would pay at Medicare rates, a sense that hospitals and doctors would charge them more. My own view is the hospitals and doctors were going to charge them more anyway. It wasn't a function of offering coverage to the uninsured, but a concern about cost shifting, a concern about regulations if they have to cover young adults under their employees' policy. Won't that drive up the premium if they can't set a ceiling on annual or lifetime benefits? Won't that drive up their premiums? And the answer to those questions is yes, but not very much. But a lot of concern on the part of the business community. Our own studies show the business community gains from this legislation. And that comes about, those that now provide health insurance gain because spouses who work for employers that don't offer coverage will now be covered by their own employer if they are affected by these provisions. So the fact that in fact the uninsured get covered, if all of this cost shifting argument's true, then the fact that hospitals don't have the bad debts should mean that they are able to give better rates to employer coverage. So I wouldn't say employers opposed it, but it kind of sat on their hands throughout the legislation. Were really, really strong. But I'll let others represent their views. So I think that the big issues really had to do with insurance, and I think of as the medical industrial complex, the device industry particularly. What was different to me about this debate is the American Medical Association and the American Hospital Association were very positively engaged. I thought the American Medical Association showed incredible leadership. Again, they had some state chapters that revolted, but for the most part, James Rohack, who was the head of the AMA, took a very positive stance, saying we need to do this. Our patients need this. We can't get our patients the care they need with this system. And the American Hospital Association was very positive about, again, maybe making this calculation that the money they were contributing would be offset by the money they were gaining, but at least being very positive. I'll go way to the back, yeah.
All of the other capitalist countries in the world, as you showed in your first slide, all of the other capitalist countries in the world, as you showed on your first slide, have better care, significantly better care at significantly lower costs. What lessons do you think we can learn from the way they organize their payment system, their health sciences education system, the organization of their physicians and other healthcare workers, and their institutions?
Well, I think there are a lot of lessons to be learned. First of all, other countries do invest in primary care. So one of my favorites isn't on that slide is Denmark, where the primary care physicians make more than the specialists. So there's real investment in primary care. Make it easy to get to people. You have a regular doctor that you're enrolled with. It's easy to get in to see them. Denmark, you can get in nights and weekends. You can call on the phone and get a doctor. A doctor answers the phone when you call. Isn't that the most amazing thing? Primary care is one thing I would say. A second thing is they move much faster than we have on this comparative effectiveness stuff. They do negotiate pharmaceutical prices. They do review their effectiveness. They either don't cover or don't pay more. Denmark uses reference pricing. All the doctors are on electronic information systems. Every 2 weeks, those pharmaceutical prices are updated. And if a manufacturer wants a bigger market share, they have to cut their price to bring it down to the lowest price that's available. So they spend a third what we spend per capita on pharmaceutical costs in part because of this very different policy. The other one is not going to be well received by some in this audience, but in a lot of these countries, different countries have different models, but in a lot of these countries, the specialists work for the hospital and they're on salary, so they are not fee-for-service, and that's in part why the incomes are comparable between specialists and primary care. The primary care are the capitalists. They own their practices. In Denmark, they get a blend of fee-for-service and capitation. So, it is salary practice for specialists, and budgets or DRGs or some payment method for the hospital that constrains the total resources going in. And I would say leverage. Even those that have private insurers like Netherlands and Switzerland, they have one system of payment of providers, and they are negotiating that rate, and that's the rate. some of these basic things about the levels, the method of payments, what's paid for, the kinds of dynamics that go in are very different decisions in these other countries.
There's actually, I would argue that there are ways to incent good behaviors other than just having hospitals hire specialists. One of the, and I'm not arguing at all with virtually everything you said, one of the perverse incentives that specialists have is the more tests that are done, the higher the income. And oftentimes these additional tests aren't even done intentionally because we don't have good electronic medical records, because we don't have the primary care physician as, pardon the metaphor, the quarterback of the healthcare system. Sometimes Dr. 1 has ordered an MRI, Dr. 2 didn't even realize that the patient already had an MRI, does second MRI, and then the third person gets the MRI, and suddenly you've tripled the cost of that test. So there's a lot of ways that we could better coordinate care, still have specialty care when it's appropriate by using the primary medical home model, where a primary care physician is the sort of the gatekeeper and the person who makes certain that the right decisions are made, but brings in specialty care when it's appropriate.
Okay, we have time for just one more question, and then we're going to take a break and come right back. Ray, you want to ask the last question? You take the mic.
So some people may know I'm a strong advocate of comparative effectiveness and population health research. The model that we're talking about seems to emphasize that. My concern, though, is to get the precision you need input on a regional basis of comparative effectiveness, as well as population health research. What works at a medical center will not work at a small hospital. What works in Montana will not work in Long Island. Is there any way for, in this design, to get that in a system of that information from the bottom up as well as the top down? Because it seems a little bit focused on the top down in making decisions.
Right, so I think a very good note on which to end this part of this session. First of all, the difference between efficacy and effectiveness. So it may work in a research environment or a setting like an academic health center, but then as it gets spread across the country to different types of health professionals may not work the same. So the ability to really do research, even post innovation, or sometimes called post-marketing surveillance, how do things really work after they go out there is a very important part of it. But the other point you're making is how much do you use a standard model in, say, a patient-centered medical home and have a structured way of evaluating that versus letting 1,000 flowers bloom from the ground up and trying lots of different things in different kinds of geographic areas. We all know that in Manhattan you've got Park Avenue physicians. That's very different than a large group practice in California, where it's a very different tradition. So these models of accountable care organizations, I think first of all you have to have some very different models that are tested, but you also then need to permit a lot of ground-up innovation. And there's a lot of language in the legislation that particularly encourages states to come forward with ideas for demonstrations, ideas for health innovation zones, ideas for safety net health systems to come in with their own approaches to accountable care. So certainly Don Berwick's model is the Agricultural Extension Service. You try a lot of different things and then rapidly find out what's working and spread the successful models. A colleague at the Commonwealth Fund, Student Government, and I published an article in Health Affairs in June on the Innovation Center and 9 major recommendations that included a lot of flexibility to accommodate the ground up innovations rather than just using the old, I would say the old demonstration model of a very rigid demonstration. But it's a challenge to methodological research to figure out how you evaluate something that's always changing, that gets modified every year, as opposed to frozen in place. But that's what we need to do. So thank you for that.
I would actually add one other thing that's a fundamental flaw in the way we do clinical research in the United States. If you look at every large major clinical trial in breast cancer or heart disease or whatever, large 20,000 patient clinical trials or 2,000 patient clinical trials, if you look at the exclusion criteria in the protocols, I can promise you that 90% of the patients with disease X have been excluded from that study. And to be able to make a robust conclusion about the other 90% from the study of the 10% is a fundamental problem. And that's why it's so vitally important to extend our studies to as broad a base of patients as possible. Because if you just confine your conclusions to 10% of the population, they aren't going to be available for the people in Montana or the people in California. We need to be smarter about how we do these studies as well.